Okay, we'll get going now. Hi everyone, welcome to the Parkinson's and Speech webinar with Jenny Pachet. My name is Emma Tornero and I'm a Client Service Coordinator for the Parkinson Association of Alberta in Calgary, and I'll be moderating the webinar. If you have any questions during the webinar, you can enter them in the chat. I'll get the chat started for everyone and then you can enter your questions as we go along and we'll get them answered at the end. Just as a disclaimer, this webinar will be recorded. All the information provided in the videos by the Parkinson Association and our featured speaker are furnished strictly for educational and entertainment purposes only. The service is not intended to be diagnostic, prescriptive, or replace the relationship, advice, and/or care of your physician. And general questions about symptoms, treatment, available medication, complementary or alternative healthcare therapies, and current research will be fielded. So just as a little introduction for our presenter today, Jenny has been a speech-language pathologist for 20 years. She's worked with adults in acute care, neurorehabilitation, and long-term rehabilitation. Her areas of expertise are stroke, brain injury, and neurodegenerative diseases such as Parkinson's disease. Currently, she's in private practice seeing clients who have issues with communication, so speech and language, cognitive communication, and swallowing. So thank you for joining us today, Jenny. I'll hand it over to you and we can get started.
Great, thank you. Thanks for joining me this afternoon. And I'm a little new with the technology, so I'm going to try out and hope I can share my screens with you to give you a little bit more information. So here we go. I'm going to share my presentation, give you a little bit more information. Let's see. Okay, so like Emma said, this is going to be a presentation on Speech-Language Pathology 101 for people with Parkinson's disease. And this section is going to be speech. I will be talking next week about swallowing. But this week, we're going to start with some speech aspects. So overview of the presentation, I'm going to give you a bit of an introduction about who I am, talk a little bit about speech and language issues in Parkinson's disease, discuss some of the treatment methods that we can use to help treat speech and language issues in Parkinson's disease, talk about when is it time to see a speech-language pathologist, give you a few internet resources, and have some time for questions too. Emma's going to be looking at questions as you post them and will let me know if there's some that I can answer right away. So as an introduction, I have a Master's of Science in Speech-Language Pathology and Audiology from California State University, East Bay. I've worked in Ponoka at the Halvor Johnson Centennial Center for Brain Injury. I've also worked at the Foothills Medical Center in rehabilitation and also in acute care, mainly with brain injury, stroke, and spinal cord populations. I've also worked casual hours over the years at the Dr. Vernon Fanning Center in their neurorehab program. Currently, I'm in private practice and I see clients with neurological issues affecting speech, language, and swallowing. So what I want to start with in this one is to talk a little bit about speech and language. And the best way to talk about disordered speech is to talk about what normal speech would look like. So I want to have a look at the anatomy and physiology of normal speech production. So how we produce speech has 5 subsystems. It's actually quite complicated. The first subsystem is actually breathing. So that happens from down in your abdomen area with your diaphragm. So breathing is our power source. That's what we use to give us power to be able to speak. The next area is phonation, and that happens at the level of your vocal cords, and it's how we produce voice. So it's easier on men, but you can see, you know, men have an Adam's apple. Well, women kind of have it too, it's just not as pronounced. And so if you put your hand on your throat there, that's where your vocal cords sit. They sit just behind that Adam's apple. And the vocal cords kind of are just 2 little elastic bands that vibrate back and forth. So once the air kind of comes up from down below, it sets those vocal cords into vibration, and all it creates is sort of a buzzing, bzzz kind of sound. But that's the motor of speech. So that's where it's produced. Then what happens to that sound is it travels up further into what we call your oral cavity and as well as your nasal cavity. And that's where that sound, that buzzing noise, kind of bounces off that cavity to create some sound. That sound, so when you look at that nasal cavity, it's also sort of that nasal versus non-nasal sound. So some people, if air is escaping through their nose, they kind of sound like air is escaping. Or when you have a cold and no air is getting out, that's where we kind of also sound like we can't say some of the sounds. The only sounds that are made by air going into the nasal cavity are M, N, and NG. Those are the only sounds that happen. All the rest of the sounds are made in the oral cavity, and they're shaped by the next subsystem, which is articulation. So articulation is how we take that sound and create words with it. So we use our articulators, the lips, the tongue, the teeth, and the jaw to be able to create those sounds. Then we have something called prosody. And prosody is sort of the musical quality of speech, the ups and the downs that occur. So that helps us to ask a question, make a statement. So it changes the color of our voice. When it comes to phonation and articulation again, we are very efficient with how we make those sounds. There's some sounds that are made the exact same way. Let's take, for instance, P and B. They're made the exact same way. Both have the lips come together and then with a little explosion. So we have P and B, made exactly the same way, but why do they sound different? They sound different because when we look at whether we turn our voice on or off at the level of the vocal cords. So I want you to try this at home. I want you to put your hand on your throat around where your Adam's apple would be. And I want you just to try saying, P, P, P. You should feel no vibration happening at that time. But now I want you to keep your hand on your throat and I want you to try doing B, B, and you should feel vibration occurring there. This also happens for other sounds like T and D. So if you put your hand on your throat and you try T, T, again, you should feel no vibration happening. But if you say D, D, you'll feel vibration happening. We have a bunch of these pairs that happen, S and Z, Ch and J, G and K. They're made the same way, but sometimes the voice is turned off and sometimes the voice is turned on. So this is sort of a side view picture of how speech happens. So we don't see our lungs at the bottom of the page, but you'll see there's sort of that gap where the vocal cords are sitting behind the bump near the larynx, and that's where those vocal cords sit. The job of that cartilage of the larynx, of that Adam's apple, is to protect those vocal cords from damage. It sort of is a hard casing to make sure our vocal cords stay safe. Then you've got your lips and your jaw and your tongue. You can sort of see it's sort of like a finger-like structure hanging down behind where it says oral cavity, and it kind of hangs down there. That's your soft palate. That is what shuts off, opens and closes to create some of the different sounds. So that M, N, and NG that I talked about that's made in the nasal cavity, that happens when your uvula or your soft palate, that little punching bag at the back of your throat, hangs down. All other sounds are made when that is closed, and then it forces the air through the oral cavity. So you can kind of see everything in there. Some of the information on there, like epiglottis and esophagus, we don't need to look at that until we revisit this again next week for swallowing. So there, you can kind of see a little bit of the anatomy. We've talked a little bit about the physiology of what a normal speech looks like. So now what do we do about disordered speech? What happens in Parkinson's disease is something that we call dysarthria. And dysarthria is the incoordination or weakness of muscles that changes the way that we speak. So for Parkinson's disease, we have what we call hypokinetic dysarthria. And hypo meaning decreased, kinetic meaning movement. So it's decreased movement that has a problem creating all the sounds that we want to make. What this looks like is monopitch, where when we speak, it's sort of everything is at the same pitch, sounds a little bit more robotic. Some of it we can call monoloudness, where everything is sort of the same amount of loudness. There's no change in emphasis. There's no getting louder. Everything sort of stays at that same level. We might have what you call loudness decay, where something starts really loud, and then as we keep talking, it gets a little bit more quiet. There can be something like increased rate, where the speech speeds up as we're talking. There might be inappropriate silences, where there's sort of these long pauses, but not in a good spot. There could be these short rushes of speech that occur, or something called palilalia. And I know Emma had a question sent to her yesterday about stuttering, and whether the question was, is there any connection between Parkinson's disease and stuttering? And it's a good question. If you had stuttering beforehand, that's usually a different type of stuttering. The type of stuttering that occurs with Parkinson's disease tends to be this palilalia, which happens, where it can be repeated sounds of speech or whole words, but the cause of it is different than regular growing up kind of stuttering. This cause is a lack of dopamine to some of the areas of the brain. And so we call it slightly different. So that's what the palilalia is. I hope that helps answer that question a little bit. Does it mean that if you had a stutter beforehand, whether it would be enhanced? They're different mechanisms, so I'm not totally sure if they're totally related. So the most frequent voice and speech problem reported by people with Parkinson's disease is a weak voice followed by imprecise articulation and a hoarse voice quality. So that hoarseness can happen, but it often tends to be a weak voice that's quite quiet. So why does this happen? Sometimes it's because of the bradykinesia. So bradykinesia is the slowness of movement and difficulty initiating movement, getting a movement started. There might also be tremor in the voice as well that can happen, and also rigidity, that increase in muscle tone that occurs. So the prevalence of speech and voice disorders in people with Parkinson's disease is it said that it was about 89% of people with Parkinson's disease have speech and or speech issues. But studies suggest that only about 3 to 4% of people receive speech treatment. So now we're going to look at how each of those subsystems that I talked about gets affected by Parkinson's. So if we go back to the beginning, that power source talking about breathing and respiration, the impairment might be muscle rigidity, or there could be some tremor happening, or this reduced amplitude of being able to move the chest wall because of that muscular rigidity. So how does this present itself? It may cause that decreased loudness where everything is more quiet. It may cause that decay of loudness where you start off really strong, but then get quieter as you go. Or it may be just not feeling there's enough breath support to say long phrases, so everything kind of gets broken up into shorter phrases. So phonation, again, that's what happens at the level of the vocal cords. You can also have muscular rigidity there, or incomplete closure of those vocal cords. If the vocal cords aren't coming together and vibrating, we end up getting different voice qualities. It might be breathy because the vocal cords aren't coming together. So air escapes and you get a breathy kind of quality. Or it could be that one is coming together, but they're not meeting properly. So you get more of a hoarse kind of quality to it. There may be a bowing of the vocal cords, where the vocal cords kind of have, again, a gap in the middle because they're bowing together and not coming flush. There might be tremor that happens, so causing a tremulous type of voice quality. There may be asymmetrical vocal cords, one that stays still and the only one that moves. Or it could be that there's just reduced movement of those vocal cords. So the speech characteristics that we get then are that breathy voice, hoarse voice, tremulous, or reduced prosody, which means we're not getting those highs and those lows. So for women, we tend to have long and thin vocal cords, which give us higher pitch. For men, they tend to be shorter and thicker, giving a lower pitch. But they move like this to do the highs and the lows for pitch. But if they're stuck because of rigidity, that's where we get that mono pitch where everything sounds the same. When it comes to resonance, that's the sound bouncing off of your oral cavity or your nasal cavity. It can be normal, or it may have reduced or inconsistent closure of that nasal cavity, that soft palate not moving at the right time. So sometimes what can happen is we'll get kind of that nasally quality that will extend over a couple of sounds before it shuts off. So for articulation, it can be a weakness in control signals. So it feels like overshooting and undershooting where your tongue is fitting in your mouth. Is it behind the teeth where it needs to be to make a certain sound? Is your jaw open enough? Is it too tight? So rigidity, that tightness in muscles. Sometimes it can be everything moving too quickly, and sometimes there can be a tremor. So this results in imprecise articulation. Often people feel like they're slurring their words a little bit. It can also be these short rushes of speech, or that palilalia that I mentioned earlier as well, or blurred syllables where everything sort of just blends together. So what is the typical progression of hypokinetic dysarthria? It usually starts with voice changes, then progresses to other speech systems. Most common features tend to be associated with phonation, so that level of the vocal cords. So you get that breathy quality, that roughness, that hoarseness happening. And then the second most common issue seems to be that articulation and problems with rate. So articulation being feeling like everything's not just sounding as crisp as it was before, sounding a little bit more slurred. It could be those short rushes of speech that are happening, that increased speed, or that inappropriate pauses that happen. So how do we treat it? How do we treat hypokinetic dysarthria? When it comes to medications and surgical interventions, there actually aren't any medications or surgical interventions that are expressly for helping voice and speech disorders, but different medications and surgeries that treat Parkinson's disease can overall have an impact. And sometimes it can be negative and sometimes it can be positive. I've had some clients who had deep brain stimulation and found that it adversely affected their speech, that their speech was much more difficult after the surgery. Their tremors were much better, but their speech was not as good. I had one woman who, if she adjusted her deep brain stimulator, she could kind of find a balance between having less of a tremor, but her voice quality being better. Also, medication like Cinnamate, depending on when you have it throughout the day, you might find that your voice is really strong at some times of the day, but then it gets a bit weaker as the day goes on or the medication wears off. So we look at speech therapy, and that intervention depends on the severity of the dysarthria. And we categorize the severity into mild, moderate, and severe. So if we look at mild dysarthria, some of the speech features that we would see might be mild or no reduction in speech intelligibility. Speech intelligibility refers to how well other people understand you. Do I understand you 100% of the time, 90% of the time, 50% of the time? So in this case, people are probably understanding you almost 100% of the time. Maybe once in a while, they're not hearing a word. There may be reduced loudness, where it's starting to get a bit more quiet. Perhaps that monotone voice quality, where there's not a lot of musical quality, not a lot of ups and downs in the voice. And a bit of breathiness, sort of that, a little bit of breathiness coming through in the voice. So what we would do in therapy is we would target different things. We would target bringing those vocal cords together better, to get better closure, to decrease that breathiness. We would work on breath support to increase that loudness, so better volume. And we'd increase the duration of the volume. So can you speak more than 3 words on one breath? One of the treatment techniques we might use is what we call LSVT LOUD. There are some other treatments that I'll talk about too that are sort of based on LSVT LOUD and are similar. But my training is actually in LSVT LOUD, so that will be mostly what I will sort of talk about. Then we also have moderate dysarthria. Some of these speech features are a reduction in intelligibility. So maybe we understand you 85% of the time to 90% of the time. There could be reduced loudness again, that monotone voice, breathiness, and perhaps some increased rate that occurs. So when it comes to moderate dysarthria, this is where people with Parkinson's disease and their spouses report more requests for repetition. This is also the stage where sometimes the fight breaks out between, I can't hear you and I'm speaking just fine, you need a hearing aid. So that's where sometimes the argument happens. I had one couple that had this, and before I started treating the gentleman, his wife said exactly that. She said, I went and got my hearing tested because he said I just needed a hearing aid, that he was speaking loud enough and I just couldn't hear him. And she said, I got my hearing aid, but to be honest, as soon as I started treatment, I didn't need the hearing aid anymore. So it is sort of one of those things where you may need a hearing aid, but it also may just be that the person needs to speak louder. So communication at this point can be difficult in those noisy kind of environments, in like a restaurant or at someone's home where there's several people at a gathering. What happens is speaking in groups becomes more difficult, and people with Parkinson's disease may tend to start to listen rather to speak in those social gatherings. And I did notice that with some of my clients. I had a client who was at the Colonel Belcher here in Calgary, and he started to withdraw, started to social isolate a little bit more because he just kind of stopped talking to people in the hallway. He stopped going for walks with his neighbor. He stopped kind of having chats with the people at his table because he just felt that no one could hear him. And for me, that was heartbreaking, and for him, because he was starting to withdraw. And we don't want that to happen. If you're a social person and you want to be able to engage in conversation, we want that to still continue. At this point, people are more often referred to speech therapy because they have that reduction in speech intelligibility. People are starting to ask them to repeat themselves more often. So some of the treatment targets that we look at would be that exaggeration of loudness, slowing down the rate of speech, and improving emphatic stress of words to improve prosody, to improve those ups and downs and that musical quality of speech. So some of the treatment techniques, we might do some LSVT LOUD or one of the other treatments that's similar. For some people, having a portable voice amplification device helps. This is not a treatment strategy necessary. This is more a compensatory strategy. Compensatory meaning it'll work for you while you're using the device, but as soon as you leave the device, all of the issues sort of return. So the portable amplification device is sort of, is like a headphone that is attached to a speaker. And when you speak into the headphone, it amplifies it through a speaker. I had one client who, he had done LSVT for 2 years. He really worked hard at it. He did well, but then he said, you know, I'm tired. I don't want to do this anymore. I don't want to have to practice all the time. I just want something that'll amplify my voice in that moment. So he bought a couple of these devices from a couple of different companies, and then he found which ones worked best for him, kept 2 of them and sent the other 2 back, and was perfectly happy with those when he needed those devices, when he was with groups of people, or even if he wanted to talk to his wife, but he just didn't have the energy that day to put in the effort that was needed to increase his volume himself. Then there are things like the behavioral rate control techniques, the pacing boards, and computerized pacing programs. I'm going to see if I can share with you. Oh, let me go up here. I'm going to do a new share and show you on here. Oh, come on. We'll do this. Oops. Okay, go into there. I hope you can see this. This is sort of what we used to do, is have a piece of wood with different colors on it, and you would touch each square with each syllable, or each word you would touch a square, but you didn't get feedback from it. Now they have some, like this is like an app on the iPad, where if you touch each one, you slow your speech down. If you go too fast, it gives you that feedback of doing it too quickly. I had a client who had this rapid rate of speech, and he was very much into using the phone, but he found that people were starting not to understand him as well. One of his most favorite things to do was actually to call 411 or the operator to get people's phone numbers. And he found it frustrating because every time he tried, can I get John Smith's phone number? He wasn't being able to be understood, and so the operator would hang up on him. So then we decided to try this, so that he would say, hello, can you give me John Smith in Cardston's phone number? It would slow him down enough that he was then able to get out the words well enough that the operators were able to help him. When he was on the phone, no one got to see that. It just became a technique for him that worked and would slow him down. Oh, I have lost my presentation. I'm sorry. Hold on one moment. I will get that back for us. Let's see where it is. It disappeared. Sorry for the technical difficulties. I'm back. Here we go. Let's see. All right, that should be working again. All right, so that is what that one was for. Now what we have is delayed auditory feedback device. This again is also a compensatory strategy. It's not a treatment strategy. There's no carryover once the device is removed, but it's similar in the sense that it has a microphone, but you have a hearing piece as well. And what it does is it delays your speech just slightly by a millisecond. so that when you have it on, you're hearing yourself speak, but slightly delayed. And what this does is it sort of tricks the brain into slowing you down, because it's really hard to speak quickly when you can hear yourself in your ear slightly delayed. It's kind of a cool little thing that can work. But again, once it's removed, you go back to the rapid rate again. When it comes to severe dysarthria, the speech features are that natural speech is no longer functional, where it's difficult to initiate speech, it's difficult to articulate speech, it's difficult to have enough breath support to produce speech. There can be those short rushes of poorly articulated speech. When speech is initiated, it may freeze in mid-utterance and be difficult to continue. Responses might be more single words or short phrases, and there might be that increased rate that occurs. So for this one, with severe dysarthria, the treatment targets are different. It becomes not just the patient's treatment, it becomes everyone needs to be quite involved. So providing the speaker with some means of communication. It may be things like an alphabet board to spell words out, where you have a board with all the letters and you point to the letter at the beginning of each word that you say. So for instance, I love you, you'd point to the I and say I, you'd point to the L and say love, point to the Y and say you. The good thing about this is if someone doesn't understand the word that you're saying as you're saying it, you can spell the word out on the alphabet board. At this point, treatment approaches need some level of partner support, and partner doesn't necessarily mean your spouse. It means any communication partner in your life. It could be your children, grandchildren, caregivers, doctor, all of the people who you communicate with become your communication partner. So although these techniques may be effective, they do impair the naturalness of speech. They may require artificial devices. Beforehand, it used to be that you could only get portable devices that cost like a minimum $7,000. That would be that voice to text, text to voice speech. With having things like Apple apps and things like that, we now have so many apps that actually are text to speech and can speak for you. I had one called Verbally on my device. I was going to show it to you, but the issue is they can't get that one anymore. But if you go onto apps in the Apple Store, there are so many text to voice apps on there that they're great to be able to type in your message and it speaks for you. Many of them will save some of your common things that you use. You can program in before you go to buy a pair of shoes. Hi, do you have this pair in a size 9 in black? You can program things ahead of time. So it's kind of nice where we used to have devices that cost somewhere between $7,000 and $30,000 to speak for us. Now you can download an app onto your iPhone or your iPad and it can speak for you, which is pretty amazing. So here are some of those treatment strategies that I mentioned, that pacing board that I showed you, the alphabet board that I talked about, having the first letter of each one, and a portable typing device if it's appropriate. So some of those things are helpful. When it comes to language issues in Parkinson's, so that was all the speech information. That was the actual production of speech, how we make words, how we put them together. When it comes to language, it's very difficult to tease out what are language issues caused by Parkinson's disease and what are language issues that just occur from natural aging. They can be very similar. The main issue that people tend to report is word finding difficulties. And again, this is one of the main concerns of most people as we age, is trying to find the word that we're looking for. Sometimes there can be grammatical difficulties where simple grammar is easier to understand than more complex grammar. So we tend to use a more simplified sentence structure, maybe more nouns, verbs, and adjectives than determiners like the and or prepositions like on, under, around. There may be this increase in hesitation and pauses. Again, that may be tied to word finding difficulties or sometimes that loss of train of thought that can occur. Again, not necessarily because of Parkinson's disease, can also be from natural aging. And there can also be this difficulty understanding complicated sentences. If there's too much information or big use of vocabulary that you're not familiar with, that might feel frustrating to try and listen to and to understand completely. So I'm going to talk a little bit about one of the treatment strategies, which is this LSVT LOUD. And LSVT stands for the Lee-Silverman Voice Treatment. And that was because this treatment was initially created to help a woman named Lee Silverman, who was being treated by some speech-language pathologists, and they wanted to help her get her voice back, her loudness back, so that her family could understand her. LSVT has been around for 30-ish years, and it is the gold standard in speech pathology for treating Parkinson's disease and speech issues with Parkinson's disease, mainly because it's been so heavily researched. There is so much research to back up this treatment. When it comes to speech pathology, every client is very different with every disorder that they come to you with, and that what works for one person doesn't always work for another. But what they found with LSVT LOUD is that it works for the majority of people with a certain type of protocol that you follow. So the goal for LSVT LOUD is that the client uses her or his louder voice automatically in daily communication, and that there's long-term carryover. The problem is a lot of patients or clients would come in to see speech therapy and they would put on that loud voice because sort of seeing the speech therapist reminded them that that's what they needed to do. Whereas as soon as they would leave, their voice would go back to being quiet again because they didn't have the cue of the speech pathologist being there. So this treatment was supposed to be like, we practice it in our session, but you use it outside of your session as well. So how does LSVT work and why does it work? Well, we have one target, and that's just vocal loudness. That's the only thing we think about is think loud. That is just the one thing. It's not all complicated. Do this, make sure this is happening. You do it all just by thinking loud. The mode is very intensive and very high effort. It's sort of like boot camp for the vocal cords. You are working them really hard, but not to the point where you're hurting them or damaging them. It's getting to them to a point of fatigue where you've exercised them. It's like going to the gym. You can't work out at the gym once a week and expect to be in great shape. You kind of have to do it more often. Calibration refers to the generalization, how well you maintain that loudness over time and across the day, and how you generalize it. So we're going to talk about each section separately. So the target of vocal loudness is not teaching you to be loud. We don't want shouting, we don't want screaming, we don't want to hurt the vocal cords. It's actually a loudness is what you feel in order to have a voice that actually sounds within normal limits. So you're training a healthy vocal loudness. We don't want to damage anything. But what they found that by treating loudness, it has a spread of effects. And what that means is that just by working on loudness, it improved people's articulation because it's very difficult to speak loudly and not move your mouth much. It's very difficult to talk loudly if your mouth isn't moving. It also, they found that it reduced that rate, that speed that people would sometimes have, because it's very difficult to talk too quickly if you're speaking loudly, unless you're an auctioneer, but most of us aren't. It can also, what they found, is improve that facial expression, so that masked quality that sometimes occurs with Parkinson's disease. By moving the mouth more, by being louder, all of that changed facial expression as well. So just by working on loudness seemed to improve all of these other areas as well. Again, when we look at the mode of how it's delivered, that intensive and high effort, its intensity across sessions. That's why the treatment's delivered 4 consecutive days a week for 4 weeks. Often I'll do 2 days, a day off, and then 2 more days. There's daily homework, which is all 30 days of that whole month. You do daily homework. And then there's daily carryover exercises as well. And what those are to give you a chance to go into the community and use that loud voice and to practice it outside of the therapy environment. So it may be, what are you doing between today and tomorrow when I see you again? And maybe I'm going to my doctor's office. Okay, so this week I want you to go up and say, hi, I'm Bob Smith and I'm here for my doctor's appointment. And you do that instead of having your spouse do it. So these are exercises that you can do over time, every single day, to get that practice. I had one gentleman who had to go to Walmart to go get more hearing aid batteries. And he said, I'm used to just sitting in the car and wait for my wife. My wife goes in and does it. But today I'm going to do it because that's going to be my carryover exercise. So he went into Walmart himself. He found one of the people to ask for help. And he managed to say, hi, I need to get some hearing aid batteries. They're this size. And he had a conversation with them and sort of felt a bit more empowered again. He was starting to withdraw, but by doing these carryover exercises, it sort of put him right back out there again, socializing and communicating with others. We also have this intensity within the session. So the session is sort of 50 minutes to an hour long. It has high effort, repetition. What's most important about that repetition is that it's done accurately. That accuracy has to be there. You can't practice with a harsh voice quality that is damaging to your vocal cords. If it's wrong, we stop you. We wait till we get a good one, and that's what you repeat. But it has to be accurate. It has to be a good quality voice. Nothing that's going to hurt your vocal cords or damage them. And you get to a point of fatigue where, yeah, you're tired, but you're not hurt. It doesn't hurt. It just feels tired. That overlearning and that overtraining is what's so important to make it automatic for everyday use. And you're competing against yourself, not the norm. We measure how loud you are in that first session, and then we want to improve you based on where you're sitting. And what they found is perceptively increasing someone's volume by even 3 decibels gives the perception of being twice as loud. So even just that small increase of 3 decibels can make you that much louder. So when it comes to calibration, that generalization, it's that the client knows and accepts the amount of effort needed to consistently produce a louder voice. And that relationship between that increased vocal effort and the result, that output of speech, is established. So you need to know how much effort to put in and to feel that when you're speaking. So why do people with Parkinson's disease benefit from LSVT loud? It increases the amplitude of movement because of that hypokinesia, which is that reduced amplitude of movement. It helps to increase that amplitude. It looks at the sensory issues, because what happens is the feedback loop between, I think I'm speaking loud enough, but not really hearing that you're speaking loud enough, that sensory loop is compromised in Parkinson's disease. So it's hard to regulate it when you're not sensing it properly. So what this does is gives you more of a feeling of how loud you have to be, not relying on how well you hear yourself, but how much effort is needed to get that louder voice. It's very simple and redundant, and it takes away from having to think too much. Your speech pathologist is thinking and they're saying, nope, that wasn't good, do it again. Yes, that's the one, do that one again. Yep, do it, yes, that's where we want it. They're the ones who are kind of molding it without you having to think too much about the pieces needed. All you're doing is thinking loud and using those strategies. So treatment for LSVT is usually a first session is an assessment. We measure the baseline of volume. We take a video so that you can compare it over the course of treatment. It's 16 treatment sessions in a month, 4 days a week for 4 weeks, and the sessions range from 50 to 60-minute sessions. How the actual sessions look is you do some daily tasks. These never change. We work on ahs, where you're doing ah for as loud and as long as you can, but it has to be good quality. We also then work on highs and lows. So you're using ah, but you're doing it high pitch and low pitch. And again, if we go back to that mono pitch and those vocal cords moving, when they're neutral and you get mono pitch, we want to start exercising them to move them so that we can get more of that musical quality that occurs. We also do something called functional phrases. And these are phrases that you use every day, like good morning, have you checked the mail, what's for dinner, what are we up to today? Things like that, that you would use maybe every single day so that you get used to saying them with a loud voice, that when you do say them throughout the day, it reminds you, it becomes that hook that reminds you to use your loud voice. So we work on those ones for 5 to 10 minutes as well. These activities never change from session to session. You get used to them over the time. When we talk about fatigue, over those 4 weeks, that first week of doing some of this can be exhausting. People feel quite tired. By week 2, they're starting to get the feel for it and not as tired. By week 3, they've got the routine down because these daily tasks are the same every week, every day. It gets easier, you're building up stamina. And by week 4, it just starts to feel automatic and starts to feel more natural. The second part of the session is we do a hierarchy. So that's 25 to 30 minutes. So it might be structured reading of 20 to 25 minutes. Week 1, we start with, like at the bottom of this slide, it says these activities change from session to session in a hierarchy of difficulty. So week 1, we're just working on words and short phrases, because that might be all that you can do because you're not used to having a loud voice and to have that stamina to carry it over too far. So we want to work on it in small chunks. So words and phrases would be the first week. Second week, we'd start doing longer sentences. Third week, we're looking at paragraphs. And fourth week is when we're looking at conversation. And conversation is probably the toughest because it's not just thinking about being loud, you're thinking about what you're contributing to the conversation as well. So trying to keep that loud voice while having a conversation is very cognitively, you have to think a lot, but you also have to be able to keep as much energy too. We also look at off the cuff. Might, as you're doing some of these exercises, ask you a question off the cuff about something else. Can you maintain that loud voice while you're doing it? Then we spend the last few minutes talking about homework and carryover assignments. Homework is doing similar to what we did in session, but doing it on your own for a shorter amount of time. Instead of 15 ahs, you're doing 6. Instead of 15 highs, you're doing 6. Instead of 15 lows, you're doing 6. You do that once a day if you've had treatment that day, and on the days that you don't have treatment, you do them twice a day. Now your calibration is embedded throughout the entire session, that thinking about how much effort did I have to put in to produce that loud voice. So some people get a follow-up appointment at 6 months. That's sort of what we're supposed to do. Some people decide that they'll return if they start getting feedback from others to repeat themselves more again. So they tend to fall out of calibration a little bit and sort of sometimes need a little kick in the pants to kind of get them back to where they were. So that's what I say down there. If there's a slip in calibration, then a few extra sessions may help to bring back into calibration. Now, to be able to do LSVT, we also have to make sure that those vocal cords are in good health, because is that raspy, hoarse voice quality due to Parkinson's, or is it due to something organic like a vocal nodule or something sitting on the vocal cords? So often what we do is we have people be seen by an ear, nose, and throat doctor or an otolaryngologist to scope those vocal cords to see if there's anything organic causing the issue. Right now in Calgary, I think the wait list to see an ear, nose, and throat doctor can be very long. And I sort of think what AHS, Alberta Health Services, has sort of done is a speech pathologist can sort of assess and see if you're appropriate for LSVT loud. If they hear something that isn't consistent with what we normally hear for Parkinson's disease, then we may refer you to be seen by an ear, nose, and throat or an otolaryngologist to make sure that what we're hearing is just from the Parkinson's disease and not something else. So I'll tell you in a little bit who sees people using these strategies. But if we do hear something, then we may send you to the voice clinic and have them check to make sure that things are okay, or have a request put in by your family doctor to an ear, nose, and throat doctor. So information taken from the fact sheet of LSVT loud, it improves both the voice and speech of individuals with PD by treating the underlying physical pathology associated with the disordered voice. Treatment focuses on improving vocal loudness and immediate carryover into daily communication, enabling patients to maintain and or improve their oral communication. It's administered in an intensive schedule. 90% of patients improve their vocal loudness from pre to post treatment. Approximately 80% of patients maintain treatment improvements in their voice for 12 to 24 months post treatment. The only reason we haven't gone beyond that is I don't think they've researched beyond the 24 months. And all patients report improvement in their ability to communicate. So Speak Out is another version. It's sort of they sort of took the elements of LSVT loud and they created Speak Out. It's very similar. The sessions are shorter. I think they're only about 45 minutes and there's fewer sessions. There's 12, I think, instead of 16. Some of the vocabulary is a bit different. In LSVT loud, we say think loud, and they talk about speak with intent. But it's based on the same principles. So the research, you should have good effectiveness from that one as well. After treatment with any of these types of things, what happens? You know, here I've done my treatment, I've done my 16 sessions, what happens next? You may, down the line, want to follow up with a speech pathologist to maintain that calibration. Or there are some programs that have groups that provide opportunities to keep practicing. So LSVT Loud created a Loud for Life program, and it's for people who've been through the program to meet up with other people to do that, to continue working on it. Often if you have, say, a program that does LSVT Loud, they've got a big population that they've worked with, they may run some groups for that as well. Same with Speak Out, they have what they call Loud Crowd, which is the same idea. It may be getting together in groups to practice. There's a program out of Ontario called Get Loud, Stay Loud, which I've referenced there, and they treat people with Parkinson's disease. Some of the SLPs are trained in LSVT Loud, and some are trained in Speak Out. After treatment, they actually have an online forum for people with Parkinson's disease that you can, if you completed either one of those programs, you can join that forum. They provide lots of webinars and lectures and speaking about different things that you can practice. Initially, when they piloted it, it was a free program, and now it's been very successful. So they've made it sort of a subscription, monthly or yearly type of fee to be part of it, but it's grown to be quite a community. It's not just people in Canada. They have people from the UK, Australia, somewhere else, I think, as well, who all are part of these continuing Loud for Life and Loud Crowd type of things, but it's all online, which is kind of cool because you can join from anywhere. So when is it time to see a speech-language pathologist? Because of decreased awareness of speech issues, it's important to listen to the people close to you who know and notice things that are changing. When you're having to repeat yourself frequently due to that low volume or imprecise articulation. Because once you're seeing a speech-language pathologist, you can be monitored as the issues change. And the earlier, the better to learn those strategies so that you can continue to use them. Who sees people with Parkinson's disease related to speech? Community accessible rehab in Calgary. I have you can self-refer, but apparently you can't self-refer anymore. You must go through your family doctor, and they have to refer you to CAR. They will then assess, and if a further voice issue, we talked about sort of hearing something that's not quite right, if that's above and beyond what's expected, they would refer you to the voice clinic for assessment. Some clinicians, like I say, use the LSVT LOUD, and some use the similar program called Speak Out. There again, it's the 2 times per week for 12 sessions. Home care, if you're already being followed by home care, you may get an assessment and some treatment or consultation by a speech-language pathologist. And then a private speech-language pathologist. Choose someone who specializes in Parkinson's disease. You can find them at the Alberta Speech-Language Association of Private Practitioners website. And if you're wanting someone who's certified in LSVT LOUD, you can find them on the lsvtglobal.com website under Find a Clinician. And here are a few internet resources. Again, Parkinson Alberta Society, Lee Silverman Voice Treatment, the Speak Out program, both of those sort of are their websites that Get Loud, Stay Loud, what I showed you before, the one that's located in Ontario. Voice amplification, this is one I believe that they have great voice amplification devices. There's also community accessible rehab services, and then for our private speech language pathologists as well. So I'll leave that up for a moment. And that is, I think, all that I have right now. So I don't know if there are some questions. I'm going to stop sharing so I can see if, go back to the, let's see, there we go. Ah, there's Emma.
Thank you for that. That was great. So as I mentioned earlier, there is the chat box there. If you guys did have a question, you're welcome to put it in the chat box. I did just want to mention the Community Accessible Rehab Program, the CAR program, that is specific to Calgary, but there might be something similar in your area. So if you're looking for something similar, or if you're wanting to meet with a speech language pathologist, connect with your client service coordinator and they'll be able to help you and direct you. I know that there is one in Edmonton as well. I believe it's called the Chris Clinic. So there is one across the province. So just connect with your client service coordinator and they'll be able to help you. Doesn't look like there's any questions, but we'll give people a moment in case they're typing. And just in the meantime, I did want to say thank you, Jenny. Thank you so much for that. We really appreciate it. As you mentioned during your presentation, speech is pretty common with Parkinson's. So it is good to have that information and be able to learn from you. And thank you to everybody who was able to attend live. As it was mentioned, next week on Wednesday, August 19th, we'll be having another webinar similar to this, but it focuses on Parkinson's and swallowing. And it'll be at 1:30 p.m. as well. And you can register on our website at parkinsonassociation.ca.
Awesome.
Yeah. Okay, well, yeah, I don't think that there's any other questions. So maybe we'll leave it at that. Thank you again. Thank you for your time and your knowledge.
Thanks, Emma.
Thanks. Bye.
Bye-bye.